Hello, everyone, and welcome to the Flint Community Webinar, your community resource every Friday at noon. We've got a lot of really excellent expertise here for you today. We're going to be talking a little bit about child abuse and neglect in Flint, and we've got some really excellent people to help us think about some of that. So we're going to get right started. We're also going to talk a little bit about the Maternal Nurse Navigator program. And so we're going to be talking to Dr. Tessler a little bit about that later. But to start, we've got Ms. Holloman and Detective Meeks here to talk to us about how we can advocate for populations. So thank you so much for being here.
Thank you for having me. And I know I saw Sergeant Meeks somewhere, but she really is like the bread and butter of a lot of the work that we do when it comes to child abuse and neglect in Genesee County, because she has the highest caseload of kids, being that she serves the city of Flint.
I see her right here. Uh-oh. Can you hear us okay?
Good morning.
Good morning.
Hi.
Hi. All right, well, tell us a little bit about what we would define child abuse as and how it's defined and what it looks like.
So child abuse is a myriad of different things that causes harm to a child. And so here at Voices and in conjunction with Sergeant Meeks, we see children, first and foremost, a majority of our cases are sexual abuse cases. And so that's where a child is either molested, sexually assaulted, and have had some kind of sexual contact with an adult or juvenile on juvenile. Then there's physical abuse. We've seen it from just a slap on the face to broken collarbones, broken bones, cigarettes on bodies, slapping children, to neglect where parents are not taking care of the child, not giving them their basic needs, not changing diapers, not giving them food, not ensuring that there's adequate food in the home. There's just a myriad of things when it comes to neglect. We've had cases where kids have been locked in like dog crates and not given food and only given a little bit of water. We also see cases where kids are witness to domestic violence, witness to some kind of horrific murder or something like that as well. And then we see human trafficking cases as well. So those all fall into child abuse and neglect. Sergeant Meeks, did you want to add anything?
No, I think you pretty much covered it. Thank you.
So you've described child abuse and neglect and sort of the caseload in Flint, and you said most of the cases look like sexual assault. How do those cases come to you?
Through Sergeant Meeks and other law enforcement. And so what happens typically in our community and is that someone either recognizes something is going on, a child recognizes something's going on, our phenomenal teachers across the county see something and they say something, they report it. And so you have these mandatory reporters that are calling it in, but then you also have concerned folk, which is what we try and raise a lot of awareness about, the way that you prevent child abuse from happening, or you help a child that's involved with, that's a victim of child abuse, is by having everybody be involved with contacting law enforcement like Sergeant Meeks or getting in touch with Child Protective Services. And so anytime a call goes into Sergeant Meeks, she's making a call over to us. And she could probably tell you more about what happens when they get the call on the police side.
Fantastic. Yes. Sergeant Meeks, please tell us.
Okay, so I get my cases one of three ways, as Nisi just talked about. A lot of times the schools and other individuals will report the children in some type of situation. So then I will get something through CPS. Also, the parents sometimes will call, and that's a walk in through the police department here, or a 911 call where the officers will go out and take the information from a individual or from a parent, and then at that point CPS is also contacted. So a lot of my work comes along with CPS, and I take it from there, contacting Voices for Children, getting the children interviewed, seeing what we have and so forth like that.
That's amazing. Lynn, do you have any questions for the team?
I do, and I love how we've, just jumped in and kind of started talking about the importance of the work, but I'd almost like to back up and talk about how long has Voices been in the community. I don't think we've gotten a chance for that. And I recall years and years ago when you moved into the building that you're currently in. So give us some background on history, and even you and I were talking about this earlier, Nisi, about the other things that you've gotten to be a part of. So give us some background on Voices, how you got here. Give us the whole thing.
Definitely. So Voices is the Child Advocacy Center for Genesee and Shiawassee counties. And what that means is that any case that involves sexual abuse, severe physical abuse, human trafficking, witness to violence, neglect, we work in tandem with law enforcement and child protective services, as well as the prosecutor's office. And it's what we call our multidisciplinary team. And we work to remove barriers, systematic barriers that kids and their families might have as it relates to reporting child abuse or telling their story. And so Voices was started in the early 2000s, but it's really modeled after the other 800 child advocacy centers across the nation. And back in the 80s, and when I talk to kids in school, I'm like, when phones were connected to the wall and we used the yellow pages, like, let's take us back there. But in the 80s, there was a case out of Huntsville, Alabama, where the child talked to 14 to 16 different people after disclosing that he had been sexually abused. And by the time he got all the way to trial, the child just shut down, froze. And it was because the system was not made for the child. It was made for each individual entity. And so they came up with a model of the Child Advocacy Center where the professionals come to the child and the professionals are working together. And so while the child comes to the center, they enter one door with their family. We're in a restored house. It's a big blue house. We called it a house with white shutters. Kids were like, you mean the big blue house? We're like, I guess it really is a big blue house. So we're in this big blue house. Kids go into this room where it was the living room of the house, and it's just decked out with toys and TV, and they come in, they play, they dance with us, we do TikTok dances with them, we try and make them feel as comfortable as possible. What they don't know is through a different door, law enforcement and CPS have come in and they're meeting with our team to figure out what we're going to talk about when we interview the child. And when I say interview, it is called a forensic interview because it's a kid-friendly way of talking to kids about trauma. It has been tested by many, many different people and many, many different entities in order to make sure that we are not leading the child. And so what happens is after the child gets comfortable with the center, he or she meets the forensic interviewer, and they go upstairs to our forensic interviewing room. And we start off with just practice narrative. We just talk about, hey, tell me what you've done. Tell me about Coco Melon. Tell me about Blippi. Like, we have learned everybody, every single dance, all the new TikTok stuff that's out there. But they just start by talking to us. We make sure that they understand. We go over some rules, make sure that they understand to correct us if we get anything wrong, to make sure that they know that we don't know what's happened. So ensure that you're giving us the most accurate details and things like that, right? And they know that our law enforcement friends and CPS friends are watching via closed circuit TV. We say, hey, we have some friends that are watching. Sometimes they're like, hi, friends. And then the interviewer also wears an earpiece so that they can hear whatever questions law enforcement and CPS have. So now we have coordinated law enforcement and CPS together to ensure that their investigations are running on the same trajectory, and whatever questions that they have, they're getting them answered in that one particular setting. And I'll just tell you a little bit more about what we do after the forensic interview is over, after the kids have told us what has happened. And sometimes they get under the table and tell us what's happened. We have a canine advocate, Daphne. She's a black lab that goes into the interview if they want her. And sometimes they tell Daphne what's happened. We bring them back to a place like, we'll talk about Blippi again, or we'll talk about whatever TV show that they want to talk about.
Is it Bluey now? Like I keep hearing
Bluey, yes. I was like, you mean
Bluey and Blippi are big staples in my house.
I was like, you mean Blue's Clues? They're like, no, Bluey.
No.
I had to figure out who the heck Bluey was, right? But even our human trafficking victims, they teach us like new songs, new dances, new social media. Gosh, like there are things that we don't know. I'm telling you, Detective Meeks gets the cases like that. But like there's like new social media apps that we have no idea about, and we're like quickly looking them up. But we're also working with the non-offending family member that's here too. So we have staff that's like, whatever their basic needs are, let's say that they're living in the house with a person who harmed the kid, we're working to find housing for them. We're working to get them food. If it is like a job situation and their job is like giving them a hard time about being at the interview or therapy, we're working with them in the community to make sure that they have what they need. We also go to court with the kids when they have to go to court. We provide free therapy on site for the kids. We have art therapy, play therapy, like any kind of therapy that will help a kid that's in trauma. We provide medicals on site right here so that the kids feel, because the kids are comfortable coming here. We have support groups. So the entire house is made just for the child. Like every color that you see in the house, everything is done with intentionality for that particular child. I'm going to pause and toss it over to Sergeant Meeks to see if she wants to add anything, because I talked for 6 minutes. My apologies.
Yeah, so actually in dealing with the children, I've always told Nisi and the rest of her staff there, I would want to play, because that is such a gorgeous place and it's so kid friendly that a lot of times when the children are being interviewed, they are anxious to talk, and then they want to go back and they want to play and so forth like that. So it's really a great place for the children to feel comfortable, to know that someone's advocating for them. They feel like they're in a safe place, and Daphne is excellent with them. A lot of times the children have so much that they are maybe afraid to talk about, but in all the kid-friendly atmosphere there, the dog and so forth, and even with just writing down what they may want to say when they're nervous and they don't want to really talk about it, they can write their stories down, which is a great help in court, because we can take what they have drawn or what they have written and add that as evidence to our report. So it's a great organization.
The two of you have brought up, I mean, we could jump into so many of these different areas, but I did want to just back up and let our audience know that this is what we are going to be talking about. So this could be a trigger for some folks, and you might hear us talking, kind of lighthearted, and that doesn't diminish from the seriousness of the topic or any other aspect of these life-changing things that have happened to this child, to this family, to these caregivers. But nonetheless, an important approach to, supporting kids who are in this situation. We did invite, and EJ, we lost you again, so we have to bring you back, but we invited our resident pediatrician, who's already been answering questions in the Q&A.
There we go.
Nodding her head. We had to bring her in because we know that our Dr. Taylor has things to add to this, and then we can jump in because we've talked about so much. We got to start. We've got to.
I want to highlight, an organization is doing their job, because I can just see how excited, how passionate you are about the services you're providing and how many resources you provide for these kids. And I agree, Heatherlyn, it is not to bring a lighthearted feel to the really incredibly tough subject, but the idea that these kids get to feel at home and get to feel joy and get to experience sort of some of that lightheartedness in a place that can be really dark, it feels really important, and I really appreciate you sharing that aspect of it. I wanted to talk to Dr. Taylor because there is an interesting space where it is not always clear in the office, right, that a child might be experiencing abuse, and sometimes it's direct and it goes to people like Sergeant Meeks, and she can connect with organizations. But in the office, what does that look like, and what should we be thinking about?
So fortunately, the type of abuse that I see most often in the clinic usually has to do with the ability of the parents or the family members to take care of their child. So it's usually not an intentional form of abuse, as physical or sexual abuse, again, can be a little bit more along those lines. So a lot of times it's just talking to the family about that, and like what we can do to connect them to resources. So if there is any sexual component, I love referring them to Voices. It's just amazing. The wraparound services that they provide is just awesome, but trying to meet the family where they're at, see what the barriers to care are. So if a family comes in, it doesn't have running water, which happens. Sometimes the first thing that a lot of people want to do is reach out and say, oh, they're not providing for their child. But like sometimes it's figuring out, who do we need to contact? Do we need to give a voucher? Do we need to do what kind of those kind of things like that? So that's a lot of the space. And sometimes when I just utter those 3 letters in that room, it just shuts down the entire conversation whatsoever. And sometimes CPS provides a lot more services and connect them with them. And so I always try and say that this is like an extra layer of support for some of these things, or just someone to be kind of a third party to kind of have a more objective view of kind of what's going on. They're there for the child who can't be there to advocate for themselves. Even if the family is trying to do what they want to do, trying to do the best that they can, or etc. They're there to represent the child and to go for the, be there for the child's best interest. And so we try and be kind of a partner in that. So a lot of times when I'm bringing up concerns about neglect, it's a lot of it is just me diffusing the scary term of CPS and what it is and what it's not, and what they can and can't do, and like kind of where their scope of practice is. And also kind of changing the way that the medical, this is kind of an aside, but a big thing that I always try to do is kind of educate our other medical staff and other medical providers what CPS is and what CPS is not. I think, again, there's huge negative connotations for the term neglect and different things like that. And it's really not supposed to be a shameful thing. It's not supposed to be shaming them. This is just, it's a flag for us to say this person needs more support, or we need to investigate this further. We need to make sure that this child is healthy. So a lot of the work that is either shifting the family, making sure that they're getting the services that they need, shifting kind of our conversation between the family, and then again, kind of the shifting the frame that we see it in the clinic, that it's not a punishment. It's not to make them feel like this is their fault or anything like that. This is just to make sure that they're getting the services that they need.
I just wanted to throw. I wanted to throw out, and Kim LaFear couldn't be here today, but CPS is doing a lot of innovative redesign around what they're doing in the community, because they know that there's this negative connotation out there. I mean, they have prevention services, and it is there to help families, just as Dr. Taylor was talking about, who are in situations where maybe the water is cut off because they lost their job. And so prevention is there to help. And CPS is really this it's like a safety net to try and provide what's necessary for the family. And they recognize that there are some situations where it truly is what Sergeant Meeks and I see every day, where it's sexual abuse or severe physical abuse or really intentional neglect. But there are cases where it's just because of the economics that have happened in a community or in a family, and they are willing to work with those families, and they have resources. In the same way, we would do the same exact thing if Sergeant Meeks has given us families where there are situations where mom realizes that dad is harming the child. So mom moves into a place that might not be safe for the children, right? But it's not safe because she wants to keep the children away from the person that's harming them. So what can we do to get them into a hotel? What can we do to get them to other family members? And that's what CPS works on. That's stuff that we do. We're all working together to try and do what's best for the children. So kudos to you, Dr. Taylor, and to the medical community, because CPS is really doing the work to redesign and uplift the fact that they want to preserve families where the household is safe for the kids. We recognize that not every household is safe, but where it is safe and there are other barriers, they're going to work with those families.
Exactly.
I
feel like
appreciate-
the whole time is just trying to reiterate that it is not a punishment. It is to help. So.
Yeah, 100%. I so appreciate that context, because this is something that we're always teaching. You articulated, like, talking to other medical providers and people who might be engaging in this setting, right? And CPS so often does come with a negative connotation of people, they're going to take my kids, right? That is the biggest fear that I hear in the office when we're talking to other people is, you know, you think there's so much guilt and shame associated with it sometimes. And I really appreciate the efforts to think about how we dispel this, because WIC is a resource, right? There are all these resources that we should be considering. And I would love for CPS to be considered alongside things like WIC and resources for women and children, as opposed to this sort of punitive thing that we go to. Dr. Taylor, I wonder if you talk a little bit about what some of that education looks like when you're talking to other people in your office. So are you sharing with them resources that CPS offers? Are you talking to your residents about when they should be doing a CPS referral? And what does that look like when you're having those conversations?
So a lot of times it's talking with the other medical providers about, what CPS does and doesn't do, and understanding that. So a lot of times when there's like economic or socioeconomic things, like a job loss, like you were talking about, I mean, I see that all the time. This is not, it wouldn't necessarily be something that I always reach out to CPS as my first thing. I want to reach out to the housing department or different things like that. And if the family's like, I need that extra step, then I'm like, then I'm going to add that layer. But kind of dispelling that idea that this is only for certain forms of neglect, and that it's and that they are going to do this or that, and it's going to be in this order, etc. And a lot about particularly if there's concerns about physical or sexual abuse, about not, like you were talking about, nice, about not doing the interview too aggressively, because those children, especially if it's a traumatic thing, that we don't want to be like having them go through that every time, and how to do that in a way that we get enough information that we know what the best next step is, but also, again, not constantly re-traumatizing the child, and being very not passing any judgment. I think that's the biggest part for medical providers, is that we are there for the family and for the child. I don't care what it was, why it happened, anything like that. I am here and I'm not passing judgment. I don't get to decide whether I think one way or another. I probably have my own opinions about what I think should happen, but that I cannot change the way that I treat the patient or treat the family or interact with them, regardless of what my personal emotions are about that. And being able to kind of take that away, because again, we're only seeing these people usually on like one of the worst days of their lives, or like really bad times in their lives, and we have to give them a lot of grace and credit for being that vulnerable with us. I mean, these are exceptionally difficult things, and be able to accept where they're at, and be more understanding, and just be more gracious with them. I'm laughing because today I was, this is totally an aside, but I was here with a patient in the hospital today, and the mom is having a very tough time, and she vented for about 20 minutes. She called me a lot of unkind things, but when at the end, she was like, I just needed to get it out and things like that. And I'm like, I know, this is like the worst day of your life. And there was questions about CPS and different things like that, because she wasn't going with the medical care. And I'm like, no, this is not appropriate use of these resources. This person just wants to be met where they're at. And again, kind of, it goes, I'm talking beyond kind of the neglect field, but the frame shift that we really got to meet them where they're at, and knowing, that this is not a punitive, this is not a carrot and a stick analogy. I think sometimes when a family doesn't want to do exactly what we want to do, we bring out the CPS stick rather than the carrot, of being like, you're such a nice family. And I'm like, and not using it like that. So again, not bringing that negative, shameful, punitive case with CPS. So, again, just giving people the grace and empathy that they all deserve on these terrible days. So
I think grace and empathy is such an important like framing here, right? Are the children experiencing abuse and neglect need grace and empathy? We get it's really easy for us to make judgments about why things are happening, right? And we don't always have insight into some of that, and grace and empathy is needed with all of those people. I really appreciated your encounter this morning, because sometimes you do just have to go into a patient room and sit down and listen and do nothing else.
That's right. The residents were all like, I can't believe, I'm like, that's what she needed. That's what she needed from me today.
She didn't need a prescription.
It has nothing to do with me. This has nothing to do with me. I was like, if that's what she needs, that's great. It was much easier than writing a prescription. So
exactly.
They just need to be heard. Some people just talk louder than others. That's all.
I love that.
Yeah.
I want to talk to Sergeant Meeks a little bit about prevalence of what child abuse and neglect looks like. And we've heard from Dr. Taylor, we've heard from DC about sexual abuse is sort of what you mostly see, and Dr. Taylor's talking about a mismatch in resources. When you think about prevalence in Flint and Genesee County, what does that tend to look like?
Well, it's something that it just tears the family, the children. You know, every child loves mom, loves dad. That's who they know from the beginning of their lives. And when the adults in their lives start to have issues, whatever it may be, substance abuse, inpatient, just sometimes not even knowing what to do because they need to have parenting classes. They were raised a certain way and now they need to learn something different. It's really, for the children, it's a hurting thing. I can remember an instance where a little boy had suffered some child abuse and being punished. And his thing was, when his mom wasn't feeling well, that's what happened to him. But his last statement was, I love my mom and I want to be with my mom. She just was having a bad day and she wasn't feeling good. Those are some of the things that we see. And then sometimes it's just that you just have mean people in the world and they take their anger and aggression out on the next vulnerable person. And that 9 times out of 10 is going to be a young person, a kid. So we try to make sure that we offer services. My one thing that I always try to think about in the minor cases, and I don't want to minimize that by saying minor, but when there may be some training that can be done, some in-home services and so forth through CPS and so forth. If there can be a learning, not to take those children out of home because they are devastated a lot of times. So we can work with the family, try to get them the things that they may need, do some training and so forth like that. It's a good thing, but sometimes it's just that we have to put them into the court system and there has to be punishment from, the judges and the courts.
One of the things you mentioned that I'm really interested in understanding is you described people might need parenting classes, or people might have experienced a certain type of parenting and then don't know how to change that up. And I think that's a really important thing for us to think a little bit about, because there are people who came up spanking kids, for example, right? And Dr. Taylor will speak to the AAP, the American Academy of Pediatrics, guidelines on spanking and policies on spanking. But so much of that is cultural and generational. Even, spanking in schools was once a thing, right? So people have come up with various exposure to what they think discipline is and what is appropriate. And I really appreciate your context that people may not intend to be doing something wrong. They just don't know any better. I wonder if all of you can speak a little bit to what that reframing looks like, what it looks like when you see people who are using different forms of discipline, but aren't intending to be abusive, although we might obviously perceive it as abusive.
So there are all kind of cultural aspects to how people live. For instance, Sergeant Meeks and Voices, we had a case where the family was from another country and believed in using a wire brush to using a wire brush on pubic hair on females to the point that it caused bleeding. And so that's one of those situations where, is that abuse or is that an education that needs to happen amongst that family? And then how do you ensure that the education happens along with it's a cultural practice that's in their community, right? And so there has to be like, this is what it could be considered if you don't like stop this practice. And we understand that this is part of like ancestral history. However, because you are in the place that you are now, and we are where we are, and there are laws, this practice has to stop. And then ensuring that this is one of the reasons why CPS is very good, is because you have them there to ensure that the kids remain safe and you can check in with them, right? And so it's an education, but it's also making sure that that education has taken place, because like you can tell a parent, like Sergeant Meeks was talking about, my mom had a bad day. Well, when you have substance use involved with abuse, like bad days will continue to happen. So if mom doesn't get the necessary help, then that is a situation where that kid needs to come out of that home, because you can try and educate, you can try and give all the resources, but if the person's not willing to do it, you have to be able to like ensure that that child remains protected.
I appreciate your whole framing of that, right? Is understanding cultural practices and background while giving data about where we are and what, you know, the consequences are here where they live, but doing that with a sense of empathy and grace and a follow-up, right? Like all of that felt so important and really a really good strategy. I wonder if Dr. Taylor and Sergeant Meeks will talk a little bit about, give any more details to that or give any other perspective.
So I'll talk a little bit. So as you were alluding to, the AAP recommends that parents don't spank, hit, slap, threaten, insult, humiliate, or shame their children as a form of punishment. And when I'm talking to parents, I have to be really careful. I was spanked as a child and I turned out okay. But that there is really good evidence that suggests that if with corporal punishment, which is basically what a lot of times that's what it is. I mean, that's what it is. It actually kind of can create a negative cycle, and children are more likely to act out or behave negatively in the future. And it also teaches the child that if you are frustrated or upset about something, that physical violence is one of the appropriate ways to respond to that. And it's just not something that we want to be teaching people. And so I try and kind of break it down like that there's good evidence to say that this is just not an effective way to punish a child. And then what are some of the other ways that we can do this? What are some of the other ways that we can, get the intended outcome that we want, that we can direct our child and also, reprimand them, but not do it in a way that's harmful to their development and growth. With the caveat that knowing that this was something that has been normalized, and it just very recently has been something that we started to change. I use a terrible example, but I'm like, we used to put leeches on people to get rid of the illness. And I was like, but we are smarter now, and we are getting better. And we have learned through experience and studies and things like that, that this is just not something that is as effective as we want to. And so talking about there's a lot of different strategies that I use to talk to parents about this. And then I try and talk about and try and again get down to their level and not pass any sort of judgment at all, that sometimes the punishing, the spanking and things like that, comes from when the parent is overwhelmed and frustrated about what's going on, and giving them the permission and I almost like the order. I give them, this is your prescription to do this, that if you're feeling frustrated, it is 100% normal. Every parent is feeling like this. Take a step back, take a minute. It's gonna be okay. It's feel your feels and then come back to it. So just giving them permission to do that, and then giving them some other tips and tricks again. So
I want to give Sergeant Meeks the last word, but I want to comment on something you said that was getting rid of corporal punishment is relatively new, right? Like relatively new. And a lot of times there's a lot of stigma around people's discipline practices, right? And we characterize certain groups as bad or good, but I appreciate the context that this is something that we have culturally done as a country even for a while, and that there are communities who might be further removed from understanding this as a practice that is not, I won't even say not ideal, that is inappropriate, right? And potentially has negative impacts. And I say potentially because I appreciated your initial comment. It was like, I was spanked as a kid and I turned out fine, right? And we have to sort of work through what that means to us, because a lot of us we were a part of a generation of kids who were spanked. So I really appreciate your contextualization there. Sergeant Meeks, I want to give you the last comment, please.
Okay, so also in dealing with punishment of children, some parents don't believe in spanking and so forth like that, and they will use other levels of punishment, but they will go too far with those also. Such as the instance of, I think they call them wall squats, where they will make a child stand, up against the wall, and then they will make them bend and stand there and hold it. And I've seen that go too far. We've had children who've had to stand there 15, 20 minutes. And I'm like, oh my God, that is excessive, and then if the child, moves or whatever, then the timer starts again. So we still even have to say, hey, that's a little bit excessive. Let's rethink that. And if that doesn't work, try taking away some of the electronics and so forth like that that the child may have before we start with so it's not just physical. A lot of times it's the mental stuff, and I hate you, I'll kill you, watch what we say. So it goes in a lot of different variables, and a lot of it's just retraining.
I appreciate that last comment. A lot of it is that we just need some training, right? Or to be retrained.
Right.
Thank you so much for your wonderful expertise, your willingness to share, your grace and empathy. I'm so thankful to all of you. And I appreciate your expertise. Thank you so much. We're going to switch gears a little bit. We were talking about kids, and now we're going to talk about moms. And I want to bring forward one of my favorite people. It's always fun when you get to hang out with your friends. So I'm going to bring Dr. Tessler forward, and he's going to talk a little bit about the Maternal Nurse Navigator program. So tell me what that is, Brian.
Yeah, so this is a really awesome opportunity that we recently brought to the community, and it is Nurse Navigator. So we have an RN who takes the position, and this was originally back in the 1990s is where it comes from. And the first program was a Dr. Freeman, and it was the Harlem Hospital Center, and it was for cancer. And that's where the concept of nurse navigators came from, was cancer. They've been mostly pushed through with breast cancer support and things like that for this nurse navigator position. But there are women's health nurse navigators. And the idea is to provide connection and to give them the connection to the navigator first. The navigator helps them to get a connection to their primary care team. And then that connection helps them connect to the medical community at whole. And this is because of trust, right? So a lot of this is trust issues. A lot of this is the system's already failed me. The system already let me down. They didn't help me. They didn't do anything for me. No one listens to me. These are just common things we hear all the time in women's health. And it's unfortunately from a really sad history of even my field coming from a very dark place. And we don't need to bring that up, but it came from a very dark place and a paternalistic place, and it still is. And OB-GYN is a field where we feel like we can just do because we're saving lives or we're saving babies or we're saving people or whatever. So it's unfortunately very paternalistic, which is a loss of trust in the medical field and the people that we interact with. And we're a lot of times a one and only interaction a woman may have with the medical system formally. So that's the sad part, is we're introducing them to the concept that medicine is paternalistic, or it is going to be somebody telling you what to do or how to do things. So the nurse navigator breaks that up and says, hey, come with me, trust me, I'm advocating for you. I'm someone that you can come back to if you're having a problem, you don't get it, it's an issue. I'm going to tell you about your test results after the doctor talks to you, make sure you actually understand them, answer your questions. So we were lucky enough to bring this forward with Brunel Fund, which is an awesome grant that's with the McLaren Graduate Medical Education and Family Medicine. And it's all about educating resident doctors for women's health. So we were able to bring this program forward, and it's been an immense help to the community. It's actually very funny, but a lot of patients are coming to our practice now and they're saying, yep, I'm pregnant and I want to have the private nurse service. And we're like, okay, that's not what it exactly is, but that's what they're looking for. But to have that person there for them, that's what they're interested in. They're interested in having this person for them that's part of the healthcare system, because it's not what their experience usually is. It's not what they usually get. And there's no control usually. So giving them back that control piece is where it kind of is what it is and where we're going with it. I think you might be frozen, Dr. EJ.
Sorry.
That's
Can you
okay.
hear me?
Yes.
You said it's not what they usually get. I'm sorry.
Yeah, just not what they usually get in the medical system is control or trust or having their opinion, just letting them know they have choices, letting them know that there's, treatment options for them. And especially, leaving our primary source of information going to, a consult or another office, it's kind of this dump thing, like, okay, go here, they'll figure it out. And hopefully you won't come back to me, with this problem, but our nurse navigator follows them. Any consult we put out, she follows them, make sure that they're set, they understood what happened, make sure the appointment happened. If there's any tests to follow up, she makes sure those are being followed up. So again, it's just giving them an advocate, giving them someone who's going to be on their side during the whole process. And let's face it, medicine is confusing. Like we're in it and I'm confused. Like, it's like, I don't know where things go half the time. And
so
then
you were saying like the private nurse
else.
service, and I was like, I'm not pregnant and I want the private nurse service because getting any resources is impossible, right? Like,
right.
So I want to back up, right, a little bit, because I want you to tell us a little bit about like why you're interested in this, and tell us a little bit about yourself. I jumped right in because I know you and I get so excited to have these conversations with you, but tell us a little bit about your training and like how you got into this idea of wanting to provide this sort of care for communities.
Sure. I am an OB-GYN, board certified OB-GYN. I'm from the Flint community. I was born here, raised here, and trained here in many aspects. I was a nurse, am a nurse still, before I became a physician, and I was in the community here at Hurley. I see Tanisa Martin, who I know, so I was a nurse in the community. Then I went back to medical school, trained at Michigan State here in Flint. Came back here for my residency training as well too, in OB-GYN here at Hurley Medical Center. And the reason that I never went anywhere else is because I never wanted to. This is my home. This is my community. These are the people that I love, that I enjoy, that I want to be part of their lives. I want them to be part of my life. Their impact means everything to me. So I never had a need to go anywhere else or do anything else, but I did it for a little while, but just to get experience in other places. But that's where my interest started developing in this. And I'll just be honest. I'm a huge mama's boy. I always have been. Supposedly I told my mom when I was 5 or 6 that I want to be a ladies doctor. I don't know what that means, but, but I think it was, I wanted to be my mom's doctor. I wanted to take care of moms. I wanted to be, make sure my mom was okay. And, my grandmother, my mom, so many influential, huge people in my life for women, and their strength, their ability to move forward, even the world's against them, is just amazing to me. And whatever I can do with whatever I have is what I want for all women that I take care of, or anyone that needs my services or identifies for my services. And, that's why I got interested in OB-GYN. I don't love the phrase that I'm a baby doctor, because I'm not, but I do deliver and catch babies, and it's a huge—
That would be Dr. Taylor.
Yeah, that's Dr. Taylor. I'm not the baby doctor. I'm the fetus doctor, but but I do the first 9 months, and then after that I'm good. But I think the big thing is being part of that human experience that is so— you can't get more human experience than that. And that's what I wanted to be part of every day and have some piece of that. And that's where my passion for this came from. And I wanted to also, I work in diversity through MSU, And another piece of this puzzle was both working with like the LGBT, the transgender community, working with the queer community, working with women. I saw this thing, and it's just in medicine, there's a distrust, there's a disconnect, there's this inability to let people make choices. And if they don't want to make the choice you want to make, then you're done with them. And it's because a lot of times they don't understand. They don't know what choices you're giving them. They don't even know they have a choice half of the time. And they think it's an all or nothing. And medicine is very threatening and distrustful. And, you know, that's where I came up with this concept and idea that we need this in our community. We need to regain the trust of our community. We need to regain the trust of women in our community. You know, when I first came back to the community, I had a lot of people say like, oh, you're at McLaren? I'm like, yeah. And they're like, do they deliver there? And I'm like, yeah, we do. And it's because we've just lost that connection. And that's where the Women's Health Nurse Navigator came from. I'm like, we got to have somebody connecting, and it can't be us, because we don't work, obviously. That's not what so that plan failed.
I take offense to that comment.
Well, not all of us, just, you know, my part. But, you know, we needed that reconnect. And I think that's what we wanted to bring around with the Nurse Navigator. And why I'm interested.
Well, right. I want to think a little bit about something you started to talk about earlier, right? So we understand this issue of maternal mortality and the disparities that exist there. And I want you to talk a little bit about how you see this Nurse Navigator program working to combat some of those disparities that we see, particularly in a city like Flint that frankly looks more like me than you.
Absolutely. Absolutely. You know, and I think I forget through my connection to everything here, or, you know, that connection in a lot of ways, but I try to find it as much as I can, either through just being part of community or who I am. But I think the idea is here is we have to understand there's a disconnect and a distrust that's in the system. And if you don't want to admit that, then you're not going to try to fix the problem. And when I talk to people in the community or in places where we're trying to reconnect maternal health resources, it's kind of like, well, I don't know why they don't come. Well, I do. And I want to tell you, and I want you to hear it from them. And that's something else that we've actually been doing, just to cite on that, is Leslie, our Nurse Navigator, has actually been finding patients who want to talk to resources and say, this is why I didn't come back. This is why I didn't understand. This is why I didn't use your resource or your service, because they need to hear it and they need to understand that. But we've shown like maternal morbidity, you know, and mortality especially, is a lot of it is based off, you know, hypertensive cardiovascular disorders around pregnancy, bleeding in pregnancy. And so much of this is unfortunately being found now that they weren't listened to, that they weren't heard, that the nurses thought, oh, it's not that bad, or, you know, or the doctor did, or whoever, you know, I don't care who it is, they didn't listen. And that's the point. But when you go to an emergency room and you really literally know people are being turned away because of their race or, you know, identification or whoever they are, and it's because they just don't think that's a problem for them, that's horrible. You know, and especially when we have to do things to the point of like, there's the project, I think I've talked to you about it, EJ, the project with the wristbands, where women who are discharged from hospitals that are anything but white would wear a wristband that allowed everyone in that hospital to know that they had hypertensive disorders or are at risk for high blood pressure disorders from pregnancy. So if they came back to the ER, there's no excuse, there's no reason that they aren't immediately seen by an obstetrician within like 20 or 30 minutes, I think the rule was. But it's that frame set when people are like, oh, that's such a good idea. And I'm like, but why does it have to be an idea? You know, and that's where my passion lies in this, and where we have to kind of like, morbidity and mortality in women is so much about the fact that we just don't listen, we just don't hear, we just don't pay attention. And we have to face it that that's just because of the history of how we treat women, period. And then on top of that, any complexity of who they are. So if they're Black race or Latina or whoever, you know, that's on top of that. That's even more disparate, you know, in farther out with less equality based on people giving them the time of day to hear them out or to hear their complaints. So that's, and then I mean, there's pain control and labor issues too that I just don't even want to get into.
I know.
I
know
do,
I
but
could
not
keep
here.
you here like all day, right? Like I could have you here. We could have this conversation for decades. So we talk about maternal morbidity, mortality, we talk about pregnant patients, right? I wonder a little bit if you would speak to the role of the nurse navigator on the other side of pregnancy, right? So we've talked a little bit about breastfeeding and lactation services. Leslie, our nurse navigator in our office, does things like follow up on breast cancer screening, right? All of those things potentiate have potential ways of decreasing disparities. And I wonder if you'd share a little bit about that.
Absolutely. And I can tell you some of the key things we've done since we put the program in place and since I started working in the family medicine residency is re-empowering patients, which a lot of people were like, what? At the beginning, they're like, why are you letting patients do that? Why would you do that? I allow partner speculum manipulation for individuals that have been through sexual trauma and don't trust me. That's fine. That's totally okay. You know,
So wait, pause. What does that mean?
Yeah.
I know what that means.
We can actually teach partners to control the speculum for insertion. This is not something that takes 4 years to learn. This is something you can teach them to do on a model in the office, and then the other partner will be more okay with them doing it than us doing it if they just trust us with that. We allow self-PAPs where they can do the pap smear without a speculum in place, which is the little open up device, the duct pill. You know, we allow them to do PAPs that way if they just have too much trauma and they can't handle it. We do the self swabs because there's no reason for me to have to do a full pelvic just to work up something like that if I know there's no other red flags or problems going on. We also allow patients time with our nurse navigator before they meet us. That's so key. They get to meet Leslie first. They talk with Leslie first. Leslie asks them, is there something or anything that you've had with a doctor, an issue with a doctor, or sexual trauma or things in your past that you want me to let doctor know before he comes in here so that he can be on page with you? So you don't have to tell him. You don't have to worry about it. You don't have to disclose that again and again. And that's another piece too, is they hate telling the story over and over again. Like, I don't know why we do that to people. That's just awful. But, you know, that's another piece of it. And then, you know, just this idea and concept of follow-up, you know, like, Leslie follows our sexually transmitted infection swabs, you know, and so many times people just get called and said, oh, your chlamydia is positive. I called something into the pharmacy for you. But do they talk about partners? Do they talk about, you know, sexual activity? They talk about better ways to protect? Do you have questions? Leslie has that ability to do that and talk with them and, you know, just chat with them about it and find out what they want to know more about. And that's, you know, shame on us, but we've become slaves to the inbox of our, you know, medical record systems. But, you know, the idea and concept is to re-empower and give them power back. And then also, you know, there's a huge knowledge fact that a lot of cervical women die from, which you do not have to die from cervical cancer anymore. And it's sad that people do, but we find out that it's because of people like me that treated them the wrong way or told them something absolutely horrible when they were doing an exam, like, I don't know why you can't tolerate this or whatever, you know, joked or made comments of something. And they're like, I'm not coming back here. I'm not going to make myself vulnerable and allow this, you know? So
you're saying that a lot of the cervical cancer screening morbidity and potential mortality is related to people not feeling safe with going to the physician to get their screening.
Absolutely. And even women that come to us for their other screenings, I've had women literally just refuse that part of the screening. And they're just like, I'm not doing it. The last time I did it, it hurt horribly. Nobody listened. We also do a lot of pain stuff in our clinic too. We have the not just a pinch phraseology that we use in our clinic because there's a horrible idea of, oh, it's just a pinch. First of all, not out of me. I'm no way, can't say it, don't know, can't. I'll disclose, I can't be there. I believe everything's horrible as far as I'm concerned. But you know, we use lidocaine products, we use blocks, we use sedation, we use whatever we can to make these things accessible to women and decrease the, you know, the discomfort, the trauma, the horridness of it as much as possible. And again, control too. We do a lot of things in the setup of our exams and things that actually come from Leslie and her research in women's safety in the office. Like we don't even think about like safety in the office from trauma and things like that. But you know, the littlest things like allowing the bed sheet to be in a triangle in front of them. So if they can't speak or they're upset with the exam, they can just throw the sheet forward, which tells me, okay, we're done, you know, because sometimes when you're in that mode, you can't speak, you know, you're just you're just caught off guard. So we try everything to create an environment that's welcoming and capable, but this increases screening. And this increases people saying like, hey, go to this office because they actually listen or they do this for you. And we've gained patients that way. Just by word of mouth and people going out there to the community and saying like, hey, I heard you had a bad experience with this one, so you should try this place. And they literally are reaching out directly to Leslie because Leslie gives her number to every single patient that is within her care. They can call her, they can leave her address. That alone, to have an actual direct number to someone in healthcare is amazing. And Leslie touches base with every single one of them on a regular basis and checks in with them and sees that they're ready before surgeries, everything. It's just so great, but it's that communication, connection, and trust. Getting that trust back is so important.
Communication, connection, and trust. I feel like that's such an important thing to leave people with. I want you to remind people how they can access the Nurse Navigator program. And then I want you to have an opportunity to leave people with any last thoughts that you might have.
Absolutely. So Leslie Yoakum is our nurse navigator, our women's health nurse navigator. She works out of the Graduate Medical Education Office for Family Medicine, which is over on Beecher Road. And it's a great office, a lot of wonderful people that really want to do the right thing for patients and take care of them. They can access her by becoming a patient of that office. So we do obstetric care, prenatal care, we do women's health care, anything that we can do. And we actually have a new chronic pelvic pain clinic that we've started, a sexual dysfunction clinic. So there's all of these things. Breastfeeding services are also available directly, just as breastfeeding. So even if you've had a baby with someone else, somewhere else, other doctor, you can see Leslie just for breastfeeding services. So that's also accessible as well too. And my thoughts always the same. It's the same thing I say, teaching medical students, teaching residents, teaching anybody that touches medicine. Please, please break this never broken because it never worked system. Just disrupt it in every way possible, because we need to fix everything we can to make medicine do what it's supposed to do, which is keep people healthy and keep people safe in every possible way. So there's my thoughts.
Dr. Tessler, thank you so much for your expertise and all the work you do in the community. We appreciate you.
Thank you.
We're going to spend the last few minutes that we have talking about some really great services that are in the community, and we're going to talk about lead abatement training. So if we could just have Mr. Carpenter talk to us a little bit about that, and we really appreciate you being here with us today. Oh, you're muted.
How you guys doing?
Great, thanks. How are you?
I'm good.
Thank you for being here.
Appreciate it for having me.
Yeah.
I know at the last minute it was supposed to be tied. I was supposed to be conducting this, but I'm happy to fill in for him.
No, I appreciate that. So you're doing this training in my building.
Yeah. Oh, yes, I am. Yes, for the first time, because normally we have this training at Michigan Works.
Okay.
So
this Monday you're having a training, and tell us a little bit about all of the things you'll be training people to do.
Okay, so with this training, I'm gonna give you an overview of what's going on. In 2022, the lead abatement firm, we started a lead abatement class with the state of Michigan to train workers and supervisors with the partners of Michigan Works. For guys to actually, for contractors to work with lead in the city of, well, not just the city of Flint, just Michigan, period. Because right now what's going on is we don't have any contractors or any service providers to tackle this problem, which has led us a huge nationwide phenomenon that's going around. Not everybody is being aware of the harms of lead and hazards that is bringing to health for children under the age of 6. So this program is called Lead Safe Work Program, which seeks education and training, clarify for individuals to be lead certified or supervisors. This program also helps establish and develop lead firms through guidance and referrals that may be provided. Anyone interested in the program can receive a scholarship that covers the cost of the training and exam for the first year. With this class, you'll just be learning about the hazards of lead, how to remove it safely, where it comes from, proper way of getting it abated.
Oh, go ahead. Sorry.
The program starts August 14th. It is from 8 to 5. It is a 4-day training. The 5th day, which would be that Friday, the 18th, would be for testing. So as soon as you get done with the class, you immediately go straight to testing. The test should take maybe about an hour to 2 hours, and then you'll be certified. The certification lasts a year. Every year has to be updated. I think the yearly cost for that would be like $35 to keep your license. Other than that, you have to update it every three years. Go back and take the test again. Other than that, you got any questions?
I don't have any questions. I was just going to say this is a wonderful resource that you are providing to people who might want to get this training. And it looks like that they can learn how to like actual protocols and procedures for removing lead and understand sort of the impact of why lead can be so toxic to our young populations, et cetera. So I wanted to shout you out and say thank you so much. It looks like that you said the training is 4 days. It's going to be in our building, the MSU College of Human Medicine Flint building, one of my favorite places to be, August 14th on Monday. And it is from, you said 8 to 4, correct?
8 to 5.
8 to 5. All right. 4 days. Thank you so much. And you've got your contact number for who people should contact if they have questions. So we super appreciate you coming on to tell people about this resource and opportunity.
All right, I appreciate you guys having me, and I'll leave everything in the chat. So you have any problems or any concerns, and if you still want to sign up, the portal is still open. We're trying to close by Tuesday. So if you need an application or you need help filling out the application, I work for the City Hall, so you can come down to City Hall and pick up application. Get it filled out. It should take you about 2 to 5 minutes to fill out. You can pick it up, or you can stay here and fill it out, and then give it right back to me, and we can get you in the program. Again, everything is free. And right now we are looking for contractors that already have a know-how of how to do drywall, how to do walls, how to read a tape measure. If you know that, please spread the word. Come down, pick up application. Let's get this. Let's get Flint lead free.
Love it. Thank you so much.
Thank you.
All right, everyone, thank you so much for your time and attention. A reminder about the 2023 Research Symposium. Deadline's been extended to Monday at 11:59, so get your work in. Thank you so much for being present with us. A reminder about the CEUs for community health workers.